based imaging diagnostic concepts in COVID-19. Really, I will give a great salute to my staff, especially all radiologists and radiographers who were on the front line. People, when suffer, we are the one to go forward, to mingle with the people, to take care, be compassionate to them, and face the challenges really from the patients. We do not bother about the contamination. We take all the precautionary steps to avoid the contamination for both patients, for the other attendants, and everybody in that radiology section or radiology room. So with a great salute to the radiographers who sacrifice their time and everything for the sake of the humanity, let me enter into the learning objective of today's discussion is going to be just a slight background of COVID and what exactly the screening, vocal screening, thermo screening, and radiology screening, and something about the imaging modalities that are applicable in this situation, and how, whether it is useful as a scanning for the patients in future prevention of the disease. What is the real role played by the plain X-ray of the chest, CT scan, as well as ultrasonography, which may be a little bit new to you. So all these things we will be touching in a shorter time, okay? In fact, you heard that from all the speakers, scientists have faced this disease into 3, and some scientists have faced it into 5. Whatever be, we can just remember in simplest form: mild, moderate, severe, and critical. Okay, radiology is useful in all these phases. The imaging will definitely be useful in all these stages. But the question comes, when exactly the radiology is applied? Because COVID-19 is proved to be a multi-system disease. It affects almost many parts of the body, especially vital organs in the body. So we have to choose many modalities of imaging in the diagnosis of COVID-19. A variety of extrapulmonary manifestations have been described now, including the affection of the skin. So it affects from the tip of the toe to the brain. So almost all the parts have been found to be affected by the COVID-19. And so radiology is going to play a major role in such diseases. In fact, when you talk about the screening, you pretty well know that vocal screening and written screening is the first and foremost thing being practiced everywhere. So you will be asked whether you have continuous dry cough, you have continuous fever, you have any loss of smell and loss of taste. Have you traveled to the COVID affected area? Do you have any contacts in your family, neighborhood? All these things are routine questions, but very, very valuable questions. So this vocal screening clinches some sort of the disease or disease-prone subjects. So then if you suspect that COVID virus is affecting him, then you go for some proof for that, evidence-based proof for that. So the first and foremost, as the Prof Cheong has put it, laboratory test is actually the anchoring diagnostic set in such cases. But then, as I told you earlier, and as she has also discussed about the sensitivity and specificity of the test is not yet so much improved. It is still in the range of 60 to 70%. So when the sensitivity and specificity is in that range, we cannot solely rely on this laboratory test alone. And especially it has been proved that it is giving a false negative result in early phase, and also false negative cases in advanced cases. So it is not very much reliable. If it is positive, we have to rely on that. If it is negative, multiple times the test has to be repeated if the clinical symptoms and signs are favorable for COVID-19. So clinically, when the patient is diagnosed as COVID-19, then we need some proof if the test, laboratory test is negative. So that answers the big question within us, whether imaging is going to be a screening test or adjunctive diagnostic tool, how? So in such cases where there's scarcity of the test, we know pretty well when the disease is spreading in a very fast manner, we are not able to supply adequate diagnostic kits to the population. So it was difficult in many countries, and also technical faults. So many countries have returned the kits imported, saying that it is faulty, but really the technical know-how is lacking there. And so the countries who have supplied the machines, they replied that nothing wrong with our machines, nothing wrong with our diagnostic kits. You have to train yourself to operate it. So this was the answer given by so many countries who supplied the diagnostic. So that was the stage. And this, as I told you, the sensitivity of the existing laboratory test is not very satisfactory. It is 60 to 70. In these cases, we have to show that a radiologist can play a vital role. And in fact, in Chinese studies, they have proved that radiology has been 98 to 100% sensitive, and the specificity is also great in radiological investigations. So while adopting radiology as a diagnostic aid, we have to adopt some safety measures. Of course, every time we have to adopt safety measures in the radiology department. That is pretty well known because of the deteriorating or hazardous effect of radiation. But still here, I highlight the new safety rules. So beside all the precautionary methods to avoid unnecessary radiation, we have to also recommend the PPE for all radiology staff, and also for self-declaration before they enter into the department, and also temperature, thermo checking for them, and facial coverings as usual, and social distancing for the patients and waiting patients, as well as for the radiology staff. And the use of personal protective equipment is highly stressed, besides the lead apron and everything. So they have to adopt all these things. Beside all these things, I have to emphasize the importance of decontamination of the equipment. That is very much essential in radiology department, because when the patient is tabled, he will be handling the tabletop, and he will be handling the cassette, he will be handling many parts in the many areas in the region. So the entire room has to be decontaminated. That's a must for every radiology room. Every radiologist, whether he owns his own unit or whether he's working in the government hospital, he has to adapt this. That's very important. And nowadays, I think, I'm not sure whether some of the sales agents have already approached you. In many countries now, this is being implemented slowly. You might have heard of C-arm, especially the orthopedic surgeons might have heard of C-arm. But U-arm is the new equipment that is being introduced in the COVID area. And this is highly, this gives high resolution pictures, and it is being used for study of all systems in the body. And it is useful for static as well as dynamic radiography. And you can do the full body imaging from the head up to the toe, just like a CT. So to that extent, the technique has improved during this emergency period, and maybe if not till now, sooner sales agents will be approaching you to buy this machine. So this machine, what is the great use of this? It can detect the subtle changes in in any organ. So that is very important. And now we are also involving the artificial intelligence, I will touch about it. The use of mobile and portable X-ray is great because the patients suffering from COVID, they cannot be transported easily to the radiology department. So because it will definitely contaminate on the ongoers and bypasses and all. So they have to be kept in that particular room, isolated room, and we have to go there. So nowadays in many countries, they just make a separate shed arrangement for the radiology outside the hospital. So that is for all suspected cases of COVID in the diagnostic trial. So all the patients must go to that, not to the main radiology department. That's a fair arrangement. But what happens to the people who are already admitted? Yes, we should use mobile and portable X-ray units to be carried to the bed and not the patient to the radiology department. So we have to go there, and after finishing the job, the entire unit will be decontaminated. So that's a routine that we are following in many hospitals. Okay, this mobile portable unit is very useful, especially in emergency room, when you decide to insert some artificial lines, and when you want to put some tracheostomy or artificial ventilation or to meet any sort of complication, this mobile and portable unit will be very, very helpful. And the basic investigation that we do is X-ray of the chest. So is it really useful to make X-ray just as a screening test? No, we cannot adopt this as a screening method. We have to do it. We have to do it when when you really suspect the case symptomatically, even if the serologic, even if the RT-PCR is negative, then you can go for the CXR to see some basic changes. So I want the audience to remember a few important points. What you should look for: you must look for multiple bilateral, small or large, basal and peripheral opacities. So this you must remember. They can be small or large depending upon the phase of the disease. They will be multiple and bilateral. Unilateral is quite rare, but in the initial stage it can be unilateral, but usually it will be bilateral, and the lesions will be in the basal area as well as in the peripheral parts of the lung. It can be also throughout the lungs. So at this point, you please remember, and depending upon the age of the disease, then the disease will manifest in a different way. Say, for example, if you look at the X-ray on your left side, you can see a well-taken X-ray chest, and you see the cardiac size is normal. But when you closely see the parenchyma of the lung, you can see multiple small opacities spread all over the lung fields. You can see on both sides of the lungs, and also patchy opacities. And you can see some round, well-defined opacities also. So this is an early stage. You have to see carefully to find out small, tiny lesions. What happens when it is an advanced case? If it is advanced, you can see on your right side, the X-ray will be like this. So you can see here, it is bilateral, diffuse, patchy opacities. Almost the lung fields are studded with opacities. So the patient is already in the emergency room, and so you can see the artificial lines and all. So this is an advanced case of COVID-19. Okay, and you can see here, say bilateral, something like butterfly wing appearance. So, but you can see some difference in the density. So it need not be of uniform density. All the opacities, depending upon the age of their appearance, they may vary in their opacity. Some may be greatly opacified, some may be less dense, So you can see difference in the density that doesn't bother. So it is definitely an abnormality, then obviously you are sick. Please don't forget at the same time to look at the cardiovascular markings. For example, here the heart is enlarged. So you can see the transcardiac diameter, more than 50% of the transthoracic diameter. And also you can see the prominence of the aorta. So it denotes that there is increased hemodynamic circulation. So these are all some of the points that you must see along with the lung opacities. So where does this CT comes? Well, if you are satisfied with the chest X-ray, should we go for CT scan? Yes, we give you a plate of flowers as a welcome tool for the CT scan in certain cases. Because we used to avoid CT scan in the initial stage because of radiation hazards. A lot of radiation we need, so we have to avoid CT scan until we really need it. When do you need CT scan? Even you suspect there is some complication or there is a diagnostic uncertainty with the laboratory test as well as with the X-ray test. Then if you think that there may be some other comorbidity, alternative diagnosis in such cases, so you have to do CT scan to prove. Suppose the test, if the other test is not available, or if the X-ray test machine is faulty, so then also you can go for the CT scan. Okay. In the CT scan, we can see clearly where are the lesion, what is the lesion, how it is distributed, and how much the lung is affected, whether it's completely damaged or it is limited or focal there. What's the shape of the lesion, whether it is associated with any other disease in the lung. So all these things you can see in CT scan. The typical CT findings will be again, just now I told you what exactly the lesion will be on the chest X-ray. That is being proved in CT scan, that is being verified, whether it is really multiple, whether it is really involving all parts of the lung bilaterally, or whether it is confined only to the peripheral or diffuse throughout the lung. Whether it is segmental or subsegmental, lobar, or all these things you can make it. And when you analyze the CT, you have to remember a few terminology, and also you should not forget to see certain structures. For example, when the opacity is less dense, you use the term ground glass opacity, GGO. When it becomes an area of dense consolidation, you can use the same word as consolidation, like any other bacterial consolidation. Then you must look for the changes in the bronchovascular bundles. The bronchi may be dilated, like traction bronchiectasis, and the vascular channels also will be dilated, and they will become more prominent, and you may be able to trace the vessels up to the periphery of the lung. So when the bronchi are dilated, the air may be within the bronchus, then it will be revealed on CT as air bronchogram. That means air within the dilated bronchi. And this finding you must be able to see. And beside all these findings, you may be able to see the wall thickening. The bronchial, not only dilated, but the walls will be thickened because of the inflammation and peribronchial cuffing. You can see that. And also it may affect the septum between the segments and alveoli. So just now, our previous speakers were discussing about the alveolar damage. So the alveoli will be completely filled with either cellular infiltrate or fluid or inflammatory cells. So sometimes, rarely, there will be hemorrhages. So all these things will make the ground glass appearance. And it may also be associated with the involvement of the pleura And so there may be minimum or moderate amount of pleural effusion that is very well can be seen by the CT scan. Sometimes there may be lymphadenopathy, so you must look in the hilar region whether there is any lymph nodes enlarged here. Okay, so in the initial stage, when you look at the CT scan on your left, you can see the less dense opacity, irregular opacity in the peripheral part of the lung. This is the lung, this is the heart, and you can see the opacity in the peripheral part is irregular, and you can see the opacity on the right side. This is also irregular, and it is very close to the pleura, so it is the peripheral part. Now, surprisingly, when you see the same lesion in a 71-year-old male, the lesions are more denser than this. So I'm just putting my hypothesis that patients with comorbidity, patients with less immunity may have more dense lesions, patients with diabetes or AIDS, so they may have more dense lesion, and the density will increase as the days goes. When the age of the COVID is increasing, the density also may increase. Okay, you see here in a 75-year-old female, this is another appearance. The opacity may not be uniform. If you look at this picture, you can see honeycomb appearance. So you can see multiple loculated appearance. These are all due to interalveolar septal thickening. So just now I was telling segmental septal thickening and lobar septal thickening, fissural thickening, pleural thickening, all may happen because of the inflammation when it crosses from one alveoli to the other, when it crosses from one segment to the other, or when it spreads from one lobe to the other. So all these findings will be obviously seen in the CT scan. Here you can see multiple lobulated areas in both sides of the lung. So you can see increased bronchovascular markings. The vessels are very prominent here. You can easily note all these findings. Here you can see likewise, so increased bronchovascular markings and also these fluffy densities, ground glass appearance.
Bro Kareem, time's up.
Okay.
Yeah.
Okay, thank you. So there may be a lot of damage to the lung, and by 3D method, you can demonstrate the damage of the lungs. It not only affects the lung, just now the presenters told that it can affect the heart, and coronary vessels also can be affected, and it may lead to the myocardial infarction. And also it may involve the brain vessels, and it may also cause infarction to the brain. And you can see multiple lesions which are enhanced after the contrast. The peripheral ring-like enhancement in the existing lesion is obvious finding in the brain. And whether the ultrasound is useful, yes. In the ultrasound also you can demonstrate these findings, and you can demonstrate the pleural line and also the opacities in the lung. So you can see here also the opacity in the ultrasound. So ultrasound also can pick up pleural fluid, where if it is a pocket of fluid or if it is massive fluid, you can pick it up. So in that way, the imaging is very useful. Only thing is patients should be correctly diagnosed by experienced radiologist to make a diagnosis of COVID-19, and he must be able to differentiate the progressive nature of the disease. And number two, if there is already existing disease, the radiologist must be able to differentiate the pre-existing disease as well as the newly forming COVID disease manifestations. So with this, I'm coming to the end of my talk. Thank you very much for your patient listening. Thank you.
Thank you, Prof Kareem, for that excellent talk. Any question? Maybe only one question, perhaps, but in interest of time. Anyone? Okay. Any question?
I mean,
from someone?
if there's no question, I just asked Prof Kareem. Thank you very much, Prof Kareem, for your excellent talk. I mean, you talk about radiological finding and for COVID patients, and you talk about the chest X-ray, CT scan, and CT brain specifically for things, and you show some kind of ring enhancement on CT brain. Can you a little bit further more like explain what do you mean by ring enhancements? Is in COVID patient, does the patient getting kind of stroke kind of symptoms, or this is kind of acute infections going on here? From my understanding of those patients, like with COVID, they might have kind of stroke, but it's looking like multiple kind of ring enhancement and some sort of acute infections. I wonder your thought on this, please.
That's a very nice question. It's well taken up. In fact, just now we were talking about the involvement of the vessels. So in COVID, it has been proved that it involves micro vessels. So when the micro vessels are involved, or we can talk this way also, when it involves a medium-sized vessels, it produces thromboembolic phenomena. So whether it is due to thromboembolic phenomena, or whether it is due to involvement of the vessels, there may be micro hemorrhages in the affected part. So in the heart and in the brain, when these vessels are involved, it may lead to infarcts. So the infarcts may be, depending upon the vessel size, the involved vessel size, the infarct size will also vary. Here we are able to see multiple quite moderate sized lesions, and it is bilateral because it is a vascular involvement. So when the vessel, the carotid vessel and its branches are involved, so it can be bilateral. And when you give the contrast, see, in a non-enhanced contrast, when you are not applying the contrast, you will be seeing a halo effect. Are you able to see the halo effect? I hope it is very well seen in the periphery because of the dead tissue. Okay, so around the dead tissue, there will be always hyperactive parenchyma and with the hyperactive vessels. So the vascular supply will be more, even in a normal infarct also, it will be like that. So when contrast is injected, the contrast flow will be increased in that area. So that is called a ring enhancement because it is only in the periphery, and so it will be called a ring enhancement. Sometimes if the blood supply is inside the lesion also, the lesion itself may get enhanced, but the enhancement at the periphery will be more than the enhancement of the lesion itself. So when the periphery is seen as a ring, it is called ring enhancement.
But Prof Kareem, do you don't think so? Like, I mean, if you're saying for ischemia, the DWI will be a good modality to look for ischemia.
Sure.
Yeah, but I can see any DWI sequence on this MRI. And the other thing is basically, if you're looking for ring enhancement, it's much more common in abscess. I'm not sure if the COVID can cause abscess.
Yeah. So definitely, it all the sequences of MRI like this, you can apply it to prove that whether it is a solid lesion, whether it's a fluid lesion, flare also can be used. So all these sequences are applied properly to differentiate various lesions. But initially in the COVID, it will be destructive lesion. So as you said, the diffusion sequences will be very useful, no doubt about it.
Thank you, Prof Kareem. I think in terms of time, I would like to thank Prof Kareem for excellent presentation.